Hello, everyone. Welcome to this webinar on RSV, and I thank you all for joining us here today from many different regions of Canada and also from different countries. Let me see. Okay, here you go. The Canadian Premature Babies Foundation sincerely and respectfully acknowledges the land of which we are situated, which is the traditional territory of the Anishinaabe, the Haudenosaunee Confederacy, and Wendat peoples. We acknowledge that the land covered by Treaty 13 is held by the Mississaugas of the Credit First Nation. We also recognize the invaluable contributions and enduring presence of all First Nations, Métis, and Inuit peoples, not only in Ontario, but throughout Canada. We approach this recognition with deep respect and gratitude for the Indigenous peoples and the land that graciously hosts us. I am Fabiana Bacchini. I am the Executive Director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. I am also a preemie parent of a surviving twin born at 26 weeks. CPBF is a parent-led charitable organization that helps families in and after an ICU through education, support, and advocacy. If you have a heart for preemies, whether you're a family or a healthcare professional, please check our website at canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who wants to see our little babies thrive. Besides webinars like this one, every Friday we host the Preemie Chats, which is our live weekly education sessions for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. CPBF has also developed education materials for you to share with families. And on the topic of RSV, we have a fact sheet in 17 languages, a common respiratory illnesses booklet, infographics, and much more. You can download from our website or reach out to our team and requested printed copies. And we have also surveyed parents earlier this year to understand their knowledge of RSV. The results are already on our website, and on November 3rd at 1 p.m. Eastern Time, we'll highlight the findings on a live session with Dr. Bosco Pace and Dr. Barry Rogers-Gray. And we're also going to have a nurse perspective, Fiona Gee from McMaster, and you can join the session on our social media channels. And now we are going to get started on today's topic. RSV continues to be the most common cause of lower respiratory tract infections worldwide. For too many infants, RSV results in serious illness. CPBF is committed to supporting education for both healthcare professionals and families about the need for RSV prevention for all infants. CPBF is proudly presenting this webinar today for healthcare professionals with the most up-to-date information as we enter RSV season. Today's session is in collaboration with the Global Alliance for Newborn Care, GLANCE, the European Foundation for the Care of the Newborn Infants, EFCNI, and the Canadian Association of Neonatal Nurses. I want to thank our sponsor, AstraZeneca, for the ongoing support of our educational sessions. And if you're watching this webinar live today, please do bring your voice to this table. Leave comments and questions on the Q&A, and you address them at the end of this webinar. It is through rich conversations like this that we can advance practice and learn together. So please participate, use the chat, and let us know where you're watching us from. And I have here today joining us live from Kingston, Ontario, Kate Jocelyn. Kate works full-time as a researcher for a biotech company and runs a vegetable seed farm with her husband. She's also a mom of two preemie girls born at 32 and 35 weeks and is a veteran parent to the ICU at Kingston Health Science Center. Kate had first-hand experience with RSV when her youngest baby, born at 35 weeks, required hospital admission and oxygen for RSV illness. Her daughter was later diagnosed with asthma and has been on puffers ever since. Kate, thank you so much for joining us here today. I think it's always very important for all of us to hear the parents' stories, the parents' perspectives, to really put into context why educations like that are so important. So, Kate, I let you share your story with the audience today.
Awesome. Thank you, Fabiana, for having me. I'm very happy to help out where we can. So a bit of backstory. In 2015, my eldest daughter was born at 32 weeks. She had a 6-week stay in the NICU, mostly due to respiratory issues, and then remained fairly healthy after that for quite a while. And then we got pregnant again in 2017 with our second daughter being born in 2018. And just before she was born, our eldest daughter was actually admitted for respiratory issues because she ended up with some kind of a cold that really set her back. Rosie, our youngest, she was born at 35 weeks in February of 2018. Her NICU stay, thankfully, was relatively short. She didn't really have too many issues. She was actually a really big preemie. But then in April of 2018, at the end of April, she got pretty sick. She was very congested, had a hard time catching her breath. She had really drawn symptoms. So we took her to Emerge, which resulted in us staying on pediatrics for a full week. And it took a while to get the test results back. It very much presented like RSV, but it was the end of the season and they weren't really sure at the time. But lo and behold, she did end up having RSV. And she required oxygen for 6 of her 7 days in her stay. For us, that was, again, another hard setback. So we had already been home. We had a second kid in the NICU. Financially, like, our eldest daughter was super excited to have her sister home, back into the hospital. And the difference now is that I was also breastfeeding Rosie. So financially, that was hard. So I had to stay in the hospital with really no food. Thankfully, my husband was able to visit because it's pre-COVID. But that was a really big challenge on us. It was another week of parking. It was another week of in-hospital purchasing of food. It was stressful on both our eldest daughter, because she was only 3 at the time. And then Rosie, after diagnosis, we had follow-ups pretty much. She went back to the inpatient clinic twice the following week because her respiratory rate was still quite high. It took probably a month for her to kind of seem a little bit normal. But then kind of getting into that next cold and flu season the following fall, every little cold that she had as a baby seemed to take a lot out of her. And she was diagnosed with like infantile asthma kind of, and on puffers before she was a year. She will be 6 in February and is still on puffers and hasn't had a break from it, which may or may not be contributing to, she is a very petite 6-year-old. She's about a year behind in growth, but is very proportionate. So unfortunately for us, that's kind of our story, but I knew of RSV before Rosie was diagnosed. Not necessarily to the extent of how easily it was spread would probably be the biggest thing. I wasn't, like, with Maggie being in the NICU for 6 weeks and we participated in FI care, we were very knowledgeable about germs and cleanliness and all that. And like, we were told about RSV and educated on it. And I think definitely experiencing it, I know now more the seriousness of it and how quickly it can go downhill and how serious it is for especially preterm infants. It's been a constant thing. So thankfully, I guess with COVID, we haven't, with all the masking and isolation, we haven't really, knock on wood, gotten too many respiratory illnesses in the last few years. But for us, every time one of our girls does get a respiratory illness, it definitely sets us back. And it's a lot more of that going right back to the NICU, and you're looking at monitors and you're worrying about every breath that they take and constantly watching them while they sleep. And then, so that's, the mental toll on us. And we're definitely always now advocating whenever, I'm always super cautious, even though the girls are getting older now, every time, one, we don't go around any babies when, if we're not feeling well, and our family is also hypersensitive about having anyone over that is under the weather as well.
Okay, Kate, thank you so much for sharing your story. And I think you highlight really well the impact and the trauma going back to the hospital after a NICU stay. So we have this webinar today for healthcare providers. What do you want them to know about your story, about your journey going back into the hospital and your baby's getting readmitted because of RSV?
I think it's always important to, on the healthcare, like the education part, which I know as the Canadian Premature Baby Foundation has been really helpful with, and educating. And I think the more of these kind of things happen, that's going to be beneficial. Obviously, being able to hopefully prevent serious illness would be step one. Maggie was born in March, so end of RSV season, and due to her size and gestation, she didn't qualify for the vaccine at that age. And we lived rurally. She was the only child at the time. And then Rosie, being born in February, but because of her weight and gestation, she also didn't qualify for the vaccine. Even though at that time we had like a higher risk with Maggie being at daycare. So obviously, like prevention is a huge part. I don't think any parent should have to sit and watch their children struggle to breathe, or having to be admitted in general. And there are lots of families who never have to go through that, but equally there are lots that do. And that's where probably now we can reach that preventative stage.
Absolutely. So that's one of the reasons why we fiercely advocate for equal access to all babies, because we hear stories like Kate over and over again throughout the year, and we truly know the impact on parents' mental health, and obviously the long-term impact on the babies when they do get readmitted severe RSV infection. But Kate, thank you so much for joining us here today. I always love having your voice in all the sessions that we do regarding RSV, because I feel that it's very important for everyone to understand the impact. So thank you.
Thank you very much for having me.
And our next speaker is Dr. Jessie Pappenberg, who practices pediatric infectious diseases and medical microbiology at the Montreal Children's Hospital of the McGill University Health Center, and is an associate member of the Department of Epidemiology, Biostatistics, and Occupational Health at McGill University. After his specialty training, Dr. Pappenberg completed a research fellowship on the molecular virology of RNA respiratory viruses at Laval University, and a master in epidemiology at McGill. As a clinician scientist, he works on the epidemiology of viral respiratory infections and has over 130 peer-reviewed publications. He actively contributes to national and provincial guidelines on RSV immunoprophylaxis. Dr. Pappenberg is also a National Advisory Committee member and the chair of NACE's Influenza Working Group. Dr. Pappenberg, thank you so much for joining us this afternoon. I know you have a lot of great information to share with our audience and the latest information on what's happening in RSV in Canada. So welcome.
Thank you, Fabiana. I really appreciate the opportunity to present today. And thanks also to Kate for so nicely, I think, kind of framing the human toll of RSV beyond the numbers of hospitalizations and emergency department visits and the efficacy of different preventions we have. I think she really put things into perspective nicely. So I'm going to share my screen now. And hopefully you are seeing that. Oops, wrong button. How's that?
It's perfect. Thank you.
Okay, thanks. So I actually framed the question, the title as a question, because I don't want to impose upon people my views, but I think that what we'll be going through today is the burden of RSV disease, especially in young infants. We'll talk about risk factors for severe disease, but also, there are options that are coming down the pipeline that are actually very soon to be available for use in Canada, where we could potentially protect all infants that are born during the RSV season. These are some the disclosures in terms of conflicts of interest that I have, potential conflicts of interest with companies that are involved in either the prevention, treatment, or diagnosis of respiratory infections. As I mentioned, the objectives that we have today are to describe the burden of disease related to RSV in all infants, including the epidemiology and risk factors for severe infection. We'll talk a bit about the impact that the COVID-19 pandemic has had on the epidemiology of RSV, and we'll summarize pediatric RSV prevention strategies, including the future, or not so far ahead in the future, use of long-acting monoclonal antibodies and maternal vaccination. So, RSV burden. RSV is ubiquitous in young children. About half of all children will have serological evidence of having had at least one infection during their first year of life, so by their first birthday. And then by their second birthday, over 90% of kids will have serological evidence of having had an RSV infection. But it's during that first infection that there's the greatest risk for the virus to get from the upper respiratory tract, where it can cause just a mild cold, and down into the lower respiratory tract, where it can cause a bronchiolitis. It is the leading cause of bronchiolitis, or pneumonia, and tends to cause pneumonia more in older children as opposed to bronchiolitis. The global burden of RSV disease is huge, and it's obviously tough to measure, but estimates have been made where we're talking about probably over 30 million cases of acute lower respiratory tract infection per year in kids under 5. Over 3 million hospitalizations due to RSV globally every year, and probably somewhere around 100,000 deaths per year due to RSV. Now, it's important to note that in high-income countries where we have prompt access to supportive care, mortality due to RSV is quite uncommon. And most often in children with severe underlying medical conditions. But in parts of the world where kids don't necessarily have that prompt access to the supportive care they need to get them through those first few difficult days, or the most difficult days of their RSV infection, that's when mortality occurs. So on the left, you see some data from a study that was performed in Quebec City, where we looked at children under the age of 3 who were either hospitalized at the CHUL, a hospital there for pediatrics, or were seen in the largest pediatric outpatient clinic in the city. And you can see that we found RSV in their respiratory secretions in nearly 2/3 of the hospitalized children with a lower respiratory tract infection, and nearly half of the kids with a clinic visit for a lower respiratory tract infection. So far and away, the leading cause of these types of infections in young kids. And in fact, RSV in Canada is the leading cause of all hospitalizations in children under 1 year of age, year in and year out. Now, in the United States, the CDC has put together this graphic showing that translates into a yearly counts among kids under the age of 5 of about 1.5 million outpatient visits, 500,000 emergency department visits, tens of thousands of hospitalizations, and somewhere between 100 and 300 deaths per year in kids under 5. These are Canadian data on RSV hospitalization rates. And while the graph on the left is a little bit older, I'd like to point out that really you see that in the first few months of life, RSV is the leading infectious cause of hospitalization, or at least in terms of respiratory viral infections, and especially during those first 6 months of life. So that first year of disease burden is nicely illustrated there, surpassing even that of influenza, which we know has a high risk of hospitalization in children under 2 years of age. And on the right, these are data from Ontario, using a province-wide population-based data. They estimated that in children under 1 year of age, you can see that's the top graph, the incidence rate of hospitalization is roughly 10 per 1,000, or roughly 1% of all children in Ontario would require hospitalization every year due to RSV. And amongst those hospitalizations, the median duration was 3 days, 5.6% required ICU care, and 3.1% required mechanical ventilation. Now, in terms of specific risk factors that we can see in the children themselves that might lead to a greater risk of RSV hospitalization, the table on the left are data from the United States in the pre-palivizumab, the pre-Synagis era. In other words, these children with at-risk conditions did not have access to any immunoprophylaxis at the time. And the first thing I want to point out is that clearly age, once again, is the most important factor with regards to the risk of hospitalization, whether it be in a healthy term infant or in infants who have a predisposing underlying medical condition. And you can see that the highest rate of hospitalization is in children under 6 months of age. And if you look at the children with congenital heart disease, CHD, they have roughly a 3-fold increase compared to healthy term infants. But then children with bronchopulmonary dysplasia, their risk of hospitalization due to RSV is actually several-fold higher than a term infant. And then finally, the last 3 columns are for children who have prematurity as a risk factor, but no other underlying medical conditions, so otherwise healthy preterm infants. And there you see there is a bit of a gradient with being more premature, leading to a greater risk of hospitalization, but it's relatively stable across gestational weeks. And you see also that it's roughly 2 times or 2.5 times that of a term healthy infant. And I also want to point out that once you get past the first year of life, that the risk then falls down to, for all of the risk categories, it falls down to something that approximates a healthy term infant during their first year of life, with the exception of bronchopulmonary dysplasia or chronic lung disease of prematurity, where they're even in the second year of life, you see a 2-fold increase compared to healthy term infants during their first 6 months of life. So that's why most immunoprophylaxis programs include bronchopulmonary dysplasia during the second year of life as an indication for an RSV prevention method, whereas the other risk factors such as congenital heart disease and prematurity alone only really tend to apply in that first year of life. So that's important from the individual patient perspective in terms of which child do we want to be the most careful with, which child do we want to apply the preventive measures that we have at our disposal. But then if you look at a population level, the figure on the right shows that actually amongst all children under 3 years of age who were hospitalized for their RSV infection in that Ontario study that I mentioned earlier, 83% had no known risk factors beyond simply young age itself. So from a population perspective, we're also looking for things that might help reduce the burden on our pediatric healthcare system that RSV poses if we could use these measures of prevention in all healthy term infants potentially. Now, these are data from the surveillance that we've been doing for RSV in the IMPACT program, the Canadian Immunization Monitoring Program Active, where we do active surveillance for vaccine preventable diseases and serious adverse events requiring hospitalizations after vaccination. And we've been doing surveillance for RSV we just completed our 6th year, but we just published a study on the first 5 seasons. And we did it in anticipation of the fact that we knew that there would be new methods to prevent RSV disease in the pipeline. These data come from 13 pediatric hospitals, so tertiary care, university-affiliated hospitals across Canada. And over these 5 years, we observed over 11,000 hospitalizations due to RSV in our centers. And 50%, half, were in children under 6 months of age, and nearly 2/3 were in children that were under a year of age. So clearly that disease burden is really overwhelmingly on the youngest children. The figure on the bottom highlights how the peak frequency of RSV hospitalizations in our program was observed in the 2nd month of life. So again, really the youngest children are being hit hardest. we saw that nearly 1 in 4 kids were admitted to an ICU. Now, it's important to note that we have there's a selection bias because this network is formed of pediatric hospitals. Obviously, there are a lot of children out there who are being admitted to community hospitals with their RSV or for their RSV infection, but if they're not sick enough to potentially require ICU care, they might not get transferred. So there is this selection bias for the most severe cases being seen at our hospitals. But what I want to point out as well is that amongst these ICU admissions, 61% were in children under 6 months of age. Our median length of stay was 4 days, again, a little bit more severe than what was seen in the average across all Ontario hospitals in the study that was done using ICIS data. I think this is an interesting study that was published not too long ago in that it's not surveillance data, it's a prospective birth cohort where they followed nearly 10,000 healthy term infants, newborns actually, throughout their first year of life. And it was performed in 5 European countries. And they did active surveillance for RSV infection, and 1 out of 4 had at least 1 RSV infection during their first year of life. And now, obviously, the children had to have symptoms in order to qualify for being swabbed and tested for RSV. And that number is a little bit less than the seroepidemiological data that I presented to you earlier, but where nearly half of kids have had evidence of infection during the first year of life. So it's possible that there are some RSV infections that go unnoticed during the first 12 months of life. But nevertheless, 15% almost required medical attention for their RSV infection, and 1.8% needed hospitalization due to an RSV infection. So that's roughly the estimate that we're seeing among a lot of different studies, somewhere between 1 and 2% in high-income countries of children in their first year of life will get hospitalized for RSV. And again, similar to the Ontario data, 5.5% of hospitals admissions required ICU care. Now let's talk a little bit about RSV seasonality. I think it's important to note so that we can plan our healthcare resources and also plan our immunoprophylaxis programs as well. So here on the left, you see lab surveillance data from the province of Quebec over the course of 4 seasons. And yes, there is some variability from 1 year to the next, but overall, I think that the curves overlap quite a bit. And you see that RSV seasonality tends to run from November to the end of March, pretty much year in, year out in the province of Quebec. But on the right, I wanted to highlight the fact that the RSV circulation happens probably at the same time as other respiratory viruses as well. And that could be either, the endemic coronaviruses. There's a bit of a lag for human metapneumovirus. That latter virus tends to circulate more in the late winter and spring. And then influenza as well. There can be quite a bit of overlap, but that can vary from 1 year to the next. And influenza seasons, as you can see, tend to have a bit more of a sharper peak, whereas RSV tends to have a bit of a broader shoulders with regards to its epidemic curve. And there's been a lot of work that's been done on the environmental drivers that influence when RSV occurs, both geographically and over time. And it's been shown that things like temperature, vapor pressure, precipitation, potential evapotranspiration, which is a fancy way of saying relative humidity, all of these things influence virus survival and influence the epidemic curves of RSV. But it's interesting to note that RSV activity year in, year out begins in the United States, at least, begins in Florida, which is actually almost has a subtropical climate, and then it tends to spread outwards from there. And we know that actually the tropical climate tends to have much less of a seasonality with regards to RSV compared to temperate climates. And the other thing, obviously, is that the southern hemisphere, the months where RSV peaks are the opposite months compared to the northern hemisphere. But even within a defined geographic area like the province of Quebec, there can be variability with regards to the seasonality of RSV. In our northernmost healthcare region, Nunavik, we see a delayed onset and a season that extends out into June. So RSV circulation in Nunavik actually is from January to June compared to what we saw earlier of November to March or April in the southern parts of Quebec. And then RSV tends to start in the more densely populated areas and then spread outwards from there into to the surrounding areas. And these are data from the tri-state area around the New York City area. And there's always been a sense that, it seems to be that there's a bad RSV season followed by a not so bad RSV season, followed by a bad RSV season, etc. And that impression was quantified by Michael Hawks and Joan Robinson and others at Alberta Children's Hospital, where they showed in the province of Alberta, there is that biannual pattern where hospitalizations in children during their first year of life does tend to follow a bit of a pattern with increased probability during one season, followed by a decrease in probability in the next. So I used to think that the middle part of this graphic was the most important in terms of determining RSV seasonality. The things we talked about, the environmental factors of humidity, solar radiation, temperature, and how they affect virus survival and the ability of the virus of being transmitted in small droplets. The environment influences that capacity for the droplets to travel, and how long the virus is going to remain infective in those droplets, and how long the virus remains infective on inanimate objects or surfaces. But what the COVID-19 pandemic demonstrated to us is that the other two sides of this graphic are equally, if not more important to seasonality of RSV. So first of all, there's immunity on the right here. And yes, there are these kind of soft factors that influence our immunity, and they have a seasonality to them in terms of the amount of sunlight that we're getting. Our diet can influence our immunity, what other respiratory viruses we might have been recently infected with. But recent infection with RSV is clearly very important as well, as we're going to talk about in a second. As we get multiple RSV infections over the course of our lifetime and across the entire age span in the population, as we get immunity from a recent infection, our antibody levels get boosted up, and then those antibody levels will kind of fade over the next few years, and the virus will change a little bit as well, leading to us becoming susceptible again. But if there are no infections over the course of an entire winter season, as was the case in the first year following the start of the COVID-19 pandemic, well, then there's a greater proportion of the population that has become susceptible over time to the virus. And then on the left, we also saw that interpersonal contacts are extremely important to the spread of respiratory viruses. Now, again, there's a seasonality to these things where school schedule influences our contacts. The temperature will influence, are we meeting indoors where there's a greater risk of transmission of respiratory viruses, or are we meeting outdoors? Our travel influences our contacts, the amount of precipitation as well. But what the COVID-19 pandemic showed is that if you dramatically decrease the number of interpersonal contacts due to public health measures that were put into place to try and limit the spread of COVID-19, for instance, that was a huge those put huge brakes on the spread of respiratory viruses, including that of RSV. But then once those pandemic restrictions were lifted and you had seeding of respiratory syncytial virus in a community, and those contact rates were occurring, well, then you had the right number of contacts between people and also a greater number of people who were susceptible to infection. And what we saw was an increase in transmission in the following two winter seasons. So let's go into that. What was the impact of the COVID-19 pandemic? And what we saw was really after the implementation of the pandemic measures in March of 2020, there was no circulation or hardly any circulation of RSV during that subsequent winter season. It was never before seen such an absence or near absence of respiratory syncytial virus during that winter. And then the following year, these are national data. They showed that there was an earlier start to the season. That season kind of spread along. But these national data obscure what was happening in the field and actually at a regional level. And we'll get into that in a second. Now, what did that translate to in terms of our impact RSV surveillance program? Our pre-pandemic average was 2,500 admissions per season. But in that first winter of the COVID-19 pandemic, we only had 58. It was really quite remarkable. But then in the subsequent year, that number increased to over 3,100 RSV admissions. So there was a significant increase in the burden of disease in pediatric hospitals in the 21-22 season. So this graphic really is just to illustrate the concepts that I was explaining before, that you have these pre-pandemic seasonal outbreaks where you have children that are born into the population. They are necessarily susceptible to RSV, but also you had persons who are older than that, who had maybe not experienced a first RSV infection. Young kids going into their second year of life who may not have experienced an RSV infection. So again, susceptibles that were accumulating, older people who throughout the age spectrum who were not, who were immune at one point, and that immunity waned. And because of that overall increase in susceptibility in the population, there was an increase in the number of cases. Now, I just want to highlight here that some people have used the term immunity debt that was created due to the pandemic restrictions that were put into place. And I don't think it's an improper term, but I think that people have maybe misinterpreted it. Yes, there was a quote unquote immunity debt in the sense that there were more susceptibles in the population. And when there are more susceptibles, they have a higher risk of there's a higher risk of having more infections. And then as this increased number of infections occurs, well, then we're going to get back to that previous balance of immune and susceptible individuals that will ebb and flow over the course of a season. But in no way does this imply that our children's immune systems were somehow damaged or weakened by the measures that were put into place to face the COVID-19 pandemic. The immunity debt is at the population level, the proportion of susceptibles in the population, not at the individual level. In fact, it's for every individual child. It's much better for instance, a 16-month-old to encounter RSV for the first time in their life and have to deal with the bronchiolitis at 16 months of age, as opposed to a 3-month-old dealing with the bronchiolitis for the first time, when the bronchioles are much smaller, when the chest wall is not as strong, and they have fewer alveoli, and they just have a much greater risk of running into trouble and requiring hospitalization. So this graph looks at the impact data, but by province and the epidemic curve across each season. And again, highlighting in the pre-pandemic period that there's a little bit of variation between provinces, but overall, those peaks occurred pretty much in the same months within a year. And then when you go into that after that near absence in 2021, in 21-22, we saw much greater interregional variability between the provinces and when they were experiencing their seasonal RSV epidemic. Quebec had a very intense and early RSV season, peaking in September, October, after having had some activity in the summertime. And it was over by January 1st. It was over. So we had to start our Synagis immunoprophylaxis program early that year in Quebec, and we finished it early as well. Whereas the prairie provinces, they actually continued to have significant numbers of RSV hospitalizations well into the spring and maybe even the early summer that year. And they had to extend the duration of their immunoprophylaxis program because there's ongoing circulation of RSV much later than usual. And then the fall of 2022 hit, And what we saw was across the country, an extremely early and intense RSV season, really flooding our pediatric emergency departments, hospitals having to create new ICU units to accommodate all these severe cases of RSV that were presenting to our care. And that intense RSV season that was very early, it was followed really quite closely on the heels with the most intense and earliest influenza season that we had seen since the 2009 influenza pandemic. So it was a really very trying time for the healthcare system when it came to pediatric care in Canada. And we've started to look at we've just finished a preliminary analysis of our impact data nationally for that most recent season. And I can't present them to you yet, but researchers from British Columbia just published their data on RSV hospitalizations at BC Children's Hospital, which is what you see on the right side of this graph. And as you can see in 21-22, they experienced an increase in hospitalizations. That's the red graph, what was observed. The green is what they would have typically expected if you followed the pandemic season, the pre-pandemic averages. And then in 22, in the fall of 22, they had a huge peak in observed hospitalizations compared to what they normally see, over twice the number of hospitalizations than what they would normally see at the peak of the RSV activity. But they also noticed that there was an increase in that season in the age. The median age increased from almost 9 months to almost 20 months of age in that 22-23 season, probably exemplifying that there were just so many RSV infections that were occurring that the tip of the iceberg, which is hospitalizations, got pushed up. And you had more kids that were more older kids that were experiencing perhaps their first RSV infection. And even though on an individual level, that decreases the risk of hospitalization, there were just so many more of these older kids getting infected that you wound up having increased number of older kids as well being admitted to hospital for RSV. So that's what happened in BC, and I expect to find similar results from our national analyses when they become available. Now, some people wondered, well, maybe it was the virus that changed in 22 that made it so different, so intense. So many infections. Maybe the virus was nastier, more virulent, or maybe it was a particularly immune-evading strain that was circulating. But no, actually, as it is usually the case, or always the case with RSV, you actually have several strains of RSV that are circulating in the same community. And these are data from the Boston area showing that even though there was a real increase in 22 in the number of cases, it was still just as genetically diverse an RSV season as you saw in the previous years. So it wasn't the virus that changed, it was the population and the proportion of susceptibles. Okay, so what have we got in terms of our ability to prevent serious RSV infections from a medical perspective? So we've had the monoclonal antibody palivizumab, or brand name Synagis, since it's been authorized for use since I think 2001 in Canada. And so over 2 decades of experience with this product. And it's a monoclonal antibody that binds the RSV fusion protein, which is the major antigenic determinant of RSV. And by antigenic determinant, I mean that when you get a natural infection due to RSV, a person will mount a neutralizing antibody response to that fusion protein, so anti-F antibodies. And this is a monoclonal antibody that targets the fusion protein, which is extremely important in the viral replication cycle. And it's been licensed for use to prevent a serious RSV, lower respiratory tract infections in specific high-risk groups of children. It was only ever studied in children with prematurity under 35 weeks gestational age, 35 weeks or less, should I say, children with bronchopulmonary dysplasia, or children with congenital heart disease. And you can see that the palivizumab has been demonstrated to reduce the risk of hospitalization due to RSV by 55% in premature infants with or without chronic lung disease. Now, one little caveat is that if you break it down by kids who are born with prematurity alone versus those that have chronic lung disease. In the premature babies, in the healthy preterm babies, it has an efficacy of nearly 80%. But in the much more fragile children with bronchopulmonary dysplasia who have very little cardiopulmonary reserve, the efficacy was actually just under 40%. So unfortunately, in the kids we want to work the best, it doesn't work quite as well. Although still, a 40% reduction in the risk of hospitalization is something worth achieving. And the reduction of hospitalization risk is 45% for kids with hemodynamically significant congenital heart disease during their first year of life. So based upon these data, the Canadian Pediatric Society, American Academy of Pediatrics, and NACI have very specific recommendations for targeted use of palivizumab. Targeted in part because we only have data on its efficacy in certain risk groups, also targeted because it's a very expensive intervention that costs somewhere between $5,000 and $8,000 per season per child. It's also a labor-intensive intervention requiring monthly intramuscular injections. And as you can imagine, it's also stressful for families to have to come in with their high-risk child for an additional visit once a month during the RSV season. Now, I'll take a second to just highlight the fact that the fusion protein, there was a relatively recent discovery in the early 2010 period where we found that the fusion protein has actually two conformations, one that's been called the pre-fusion conformation and the other the post-fusion conformation. It turns out that if you the pre-fusion conformation actually elicits a much stronger antibody response with antibodies that have a much greater affinity for the pre-fusion conformation than the post-fusion conformation. There have been several attempts at developing RSV vaccines using what we thought was the only conformation, the post-fusion conformation of the protein. In young infants, there was a disastrous study published in 1968, but conducted during the late 1960s, at a time when there was much less preclinical evaluation of a new vaccine that went into play. By preclinical, I mean cellular data and also animal model data. And this vaccine was tried in healthy term infants, and unfortunately, it was shown that the infants who received the active formalin inactivated vaccine back in the 1960s actually had an increased risk of developing severe RSV infection if they did acquire natural infection. It turned out that formalin inactivated vaccine, the post-fusion protein, shifted the immune response from a Th1 response to a Th2 response, but the antibodies it generated were not neutralizing. So you didn't have the cellular immune response, and you didn't have an efficacious antibody response to dampen viral replication. So it actually made for worse disease after natural infection. Other quote unquote failures of RSV vaccine development were both attempts at having a fusion protein, post-fusion protein vaccine in the elderly, developed by Novavax. Unfortunately, that vaccine in phase 3 trial did not meet its efficacy requirements, so it didn't work well. And also in pregnant persons to protect the young infant through passive transfer of antibodies, Novavax, again, in the phase 3 trial, although there was a proof of concept that 40% of kids, there was a 40% reduction in hospitalization, the confidence intervals were too wide and the point estimate interval was too low according to the predefined FDA and EMA criteria. So that also failed, again, with a post-fusion protein. But the discovery of the pre-fusion protein was a game changer, as people like to say. But just to get back to palivizumab, which is currently still pretty much the only product we have available in Canada for the prevention of RSV in young infants. And these are the NACI recommendations in terms of the risk groups for whom it's strongly recommended in red, and for whom there's a discretionary recommendation in black. But what's most important for everybody, I think, on this call to realize is that each province is responsible for their own palivizumab programs. And there's a huge amount of variability across provinces, which I think has also led to some health inequities, as the indications for palivizumab are not the same across provinces. Some provinces use different thresholds for prematurity. Some provinces use risk scoring tools for late preterm infants. And there are some indications such as either Down syndrome or cystic fibrosis, in whom palivizumab has never been studied, that for whom in some provinces it is an indication and others it's not. So hopefully we'll be able to move away from this palivizumab patchwork as we have new options available to us. So the option that was just recently approved for use in Canada in this past April of 2023 is nirsevimab, another long-acting monoclonal antibody developed by the same company that developed palivizumab, MedImmune. So nirsevimab, like palivizumab, targets the fusion protein. Now, its big distinction versus palivizumab is that one dose of nirsevimab will give you protective antibody levels for at least 150 days. In other words, one dose to protect for an entire RSV season, as opposed to the monthly injections of palivizumab. How did they manage to do that? Two things. One, it's targeting the pre-fusion conformation of the RSVF protein, giving it a much higher affinity for its target. And two, they modified the FC portion of the antibody that allows it to have a longer or more stability and a longer half-life before it gets degraded in the patient's blood. Now, unfortunately, this product is not yet available in Canada. Many provinces had decided to make the move away from palivizumab to nirsevimab as it had been authorized for use. But unfortunately, the producer, Sanofi, cannot guarantee that there will be any product available this season in Canada, although it may become available later on in the winter this year. So I think everybody needs to be kind of aware that there may be a switch from palivizumab to nirsevimab in certain provinces if the product availability changes. So these are the RCT data summarized for nirsevimab. I want to point out a few things. One is that there are different outcomes that are being presented here, whether it be any medically attended lower respiratory tract infection due to RSV or hospitalization due to RSV. But across the different populations that were studied, so in preterm infants, 29 to 35 weeks gestational age, and also in late preterm infants and healthy term infants, for all the outcomes across all populations, we're looking at roughly a 75% reduction in these outcomes with nirsevimab compared to placebo. In other words, 75% reduction in hospitalization risk for both the preterm infants as well as healthy term infants. Remember, palivizumab had never been studied in healthy term infants. So this is really a fantastic opportunity, perhaps, to reduce the overall burden of RSV disease, in addition to targeting those infants that are highest risk. And what about the other conditions in whom palivizumab is indicated, certainly in the United States and across almost all jurisdictions worldwide? So congenital heart disease that's hemodynamically significant, congenital lung disease, and extreme prematurity less than 29 weeks of age. We don't have vaccine efficacy data against placebo because obviously it would not have been ethical to give these infants placebo. But there was a trial where infants were randomized to either palivizumab or nirsevimab, and although it wasn't powered to detect differences in efficacy, the efficacy was similar between these two products. The study was powered for safety, and it showed that palivizumab and nirsevimab were equally safe. And I think those of you who have worked with palivizumab know that there are really very few adverse events that occur, and in terms of serious adverse events, really only the very unusual case of anaphylaxis. So it's been shown to be safe in these patient populations, and also that the antibody levels that were obtained in these high-risk groups were what was considered met the criterion for success to achieve exposures that were predicted to be protective and above target in all three of these high-risk groups. So for these, it is on this basis that the FDA and Health Canada approved its use in high-risk groups that we described here. So when are you going to give nirsevimab? Because we know it works for at least 150 days, but we presume that the efficacy will wane after that. So what the US CDC have proposed, and NACI and the provinces have yet to come out with their recommendations, but NACI will publish its recommendations in the spring of 2024. So you can expect to have recommendations for the following winter season on nirsevimab, but also on maternal vaccination. And the CDC have recommended that infants younger than 8 months of age at the start of the RSV season would receive nirsevimab, and all infants born during the RSV season would receive nirsevimab as well. So we know it works, we know it's safe, but at what cost will it prevent hospitalizations and medically attended lower respiratory tract infection due to RSV? And that's really where the rubber hits the road, so to speak. The CDC estimated that the implementation of nirsevimab in all healthy term infants would cost roughly $100,000 per quality adjusted life year gained. And in other words, that's the ICER, the incremental cost effectiveness ratio. So I don't know if you're familiar with ICERs and QALYs, but usually in a way of trying to understand, is this an efficient use of healthcare resources, we've had to develop this standardized metric to evaluate very different types of interventions in different age groups. And $100,000 is uncomfortably expensive. Nevertheless, the CDC did recommend its use for all infants in the United States. Canadian analyses are underway by the Public Health Agency of Canada, and they will contribute to the NACI recommendations that will be published in the spring of 2024. I just wanted to point out that there have been other long-acting monoclonal antibodies that unfortunately did not work and failed in their phase 3 trial. Regeneron had a product that unfortunately, RSV became resistant to it in its phase 3 trial. Up until now, the finding of nirsevimab resistance mutations is a very unusual event, less than 1% of circulating RSV strains, but it's important to continue this ongoing surveillance from a virologic perspective. Now, I mentioned to you the idea of vaccinating the pregnant person so that that person develops their own antibody response against RSV. That surge in antibodies will translate also into a passive transfer of antibodies during the 3rd trimester to the baby. And then the baby is born with a passive immunity. In other words, the baby's not making their own antibodies.
Alden?
They will... they will have their own immunity, but those antibodies will wane over time. But will protect them during those first months of life when they are most at risk for hospitalization. And these data show that, the antibodies wane over the first few months, but they appear to be protective during the first 6 months of life. And you can think that the closest analogy to this is our vaccination against pertussis, which is recommended in the 3rd trimester of all pregnancies in order to protect babies during those first few months of life before they've mounted an immune response to their first dose of pertussis vaccine at 2 months of life, and they're at high risk of neonatal pertussis. So this is not to protect the pregnant person, but really to protect baby. This approach using the Pfizer product leads to a reduction of nearly 70% in RSV medically attended disease during the first 6 months of life, and over 50%, nearly 60% reduction in hospitalization. So it works, maybe not as effective as the monoclonal antibody, but it is effective. There is one safety signal. That there was an increase in the absolute number of preterm deliveries in the arm that received the vaccine as opposed to the placebo. And that translated into an increased relative risk of 1.2. Now that is a 20% increase, but it wasn't statistically significant. So it's unclear whether this is just a statistical anomaly. And if the trial had continued for, enrolling twice the number of patients, maybe that would have regressed towards the null and there wasn't a difference between the two groups. Or perhaps if the trial had continued, we would have seen a statistically significant increase in prematurity. So we are left with a certain amount of uncertainty with regards to that. But what the CDC has done, what the FDA has done to mitigate that risk is it only approved the use of the Pfizer product in pregnancy from 32 to 36 weeks gestational age. So, and because the average there was a delay of 4 weeks between vaccination and preterm delivery, that should reduce or practically eliminate the risk of preterm delivery if there is a true association with the vaccine product. And initially, I had my doubts whether this was a true association. But it's important to put this into context with a recent GSK phase 3 trial that they had a similar RSV product for vaccination during pregnancy that unfortunately did have a significant increase in the risk of premature delivery, but that risk was only observed in low and middle income countries. So there's something going on there that we don't understand very well. And if we are to use this type of approach, I think it would be wise to have some sort of mitigation in the way that the FDA did. The GSK product development was completely halted based upon this increased risk. So again, cost will be an important consideration. The CDC's estimate had an ICER of over $200,000 per quality if you integrate the risk of prematurity within that analysis. So the considerations that we have for maternal vaccination is that it seems that the efficacy may not be quite as good as that of nirsevimab. The issue of waning seems to be maybe more pronounced than the monoclonal antibodies. So one way of counteracting that is to recommend its use only through during September through to January. Therefore, you wouldn't have older children born with these protective antibodies that might start waning at the beginning of the RSV season. What is the acceptability of this approach compared to monoclonal antibodies? There are national studies underway where we are surveying expecting families and trying to see, well, what do the partners who are expecting a child, would they prefer vaccination during pregnancy? Would they prefer a monoclonal antibody injection at the time of birth? And those results are not yet available for Quebec and Canada. But we do know that vaccination for pertussis during pregnancy is only 75% coverage in Quebec. And vaccination for influenza is even less, 50% across the country. Which is surprising considering that influenza is a high-risk state. Pregnancy is a high-risk state for influenza infection. So influenza is worrisome for the mother, for the pregnant person, higher risk of hospitalization with an influenza infection. And also there's the added benefit of the passive transfer of antibodies to baby. And it's been shown in randomized trials that vaccinating the pregnant person protects the infant from lab-confirmed influenza during the first 6 months of life. Cost effectiveness will be an issue. Also, we know that this approach of vaccinating the pregnant person will not be able to protect babies who are born too prematurely to benefit from that passive transfer of antibodies. So if we do implement maternal vaccination, it would have to be also complemented by antibodies, long-acting monoclonal antibodies in certain high-risk groups that may not have benefited from the vaccination. And then finally, there's that association with prematurity. And as I mentioned, the FDA approved the use of the Pfizer product only from 32 to 36 weeks gestational age of pregnancy. So Health Canada is currently reviewing the Pfizer product for vaccination during pregnancy, and we expect the decision either by the end of this year or the first quarter of 2024. And then NACI will come up with recommendations integrating not only the use of long-acting monoclonal antibodies, but as well the potential use of vaccination during pregnancy. So, in conclusion, I hope that we've hammered home the point that RSV burden is really big in pediatrics, especially among the youngest infants who are the most vulnerable to severe disease. There are established risk factors for severe RSV, and we need to make sure that we have the tools at our disposal to help prevent disease as much as we can in those high-risk groups. But as well, we need to understand that those high-risk groups represent a minority of all RSV medically attended illness and hospital admissions, and it would be really very, I think, impactful on the healthcare system if we had ways to prevent RSV disease burden in all infants. Local and national RSV surveillance remain very important. Long-acting monoclonal antibodies such as nirsevimab against RSV and vaccination during pregnancy could have an important role in reducing RSV burden in young children. But be on the lookout for your provincial recommendations regarding the use of palivizumab this season and potentially a switch to nirsevimab in certain provinces if product availability changes this winter. So people often ask me, what's going to happen this winter? Are we going to have a bad RSV season like last year? I think everybody's crystal balls are somewhat muddied after the COVID-19 pandemic. But one thing we know for sure is that vaccination offers protection. So make sure you get vaccinated against influenza and protect high-risk children 6 months of age and over against influenza with the vaccine. And for infants who are eligible for palivizumab prophylaxis, make sure that we cover them and protect them during the first RSV season. So I'm happy to take any questions at this point.
Dr. Papenburg, thank you so much for your presentation. Always very enlightening and a lot of new information. We have a lot of questions. We start to unpack a little bit. If you have questions, please do send them on the Q&A so I can watch them all. So let's start here. In some provinces, switch to nirsevimab in the new year, and some infants might have had a number of doses. What would the conversation be for parents? Monthly and now 150 days is starting January, February. Oh, you're muted, Dr. Papenburg.
I'm sorry, that was very 2020 of me. So I agree. So there's, changing a RSV prevention program from one season to the next already would require a lot of education for really mostly, I think, for healthcare professionals who need to identify in whom that change is, what is the population that in whom the intervention is going to be indicated. We would anticipate that most provinces, if they switch to nirsevimab, because it's actually less expensive than palivizumab, might broaden their indications to include other high-risk populations. So we need to educate healthcare professionals so they can identify the at-risk children that will be eligible for nirsevimab if that is a broader group than what is currently used for palivizumab. And then the families as well, in terms of the difference of one dose every month versus one dose for an entire season. I haven't seen any results of studies of surveys of families with regards to their preference of would they prefer a tried and true method that requires monthly injections like palivizumab versus a newer product like nirsevimab that only requires one dose per season. But I think that it's not really going to be in the hands of families, that type of decision. I think it's going to be a programmatic decision. Those provinces, if the opportunity for change is there, and there has been no guarantee yet, as far as I understand, that there will be that opportunity, but should it arise, it needs to be programmatic, and it needs to be the province that will decide, okay, these are the infants that will receive nirsevimab now. Perhaps there will still be some infants that receive palivizumab. I think the more layers of complexity there are, the more difficult it becomes. I can tell you that in the province of Quebec, we decided, even before this lack of availability of nirsevimab became apparent, it was already decided that there wasn't enough time to implement a new program with a new product. And we were going to stick this season with palivizumab, regardless of nirsevimab availability. So different approaches in different provinces, and every province's program has different field implementation issues in terms of how it's organized. So I really, I think all I can say in terms of advice, and advice that you should be giving your high-risk patients, is keep your ears and eyes open if there are any changes that will occur, and then contact all the high-risk groups patients once those changes come into effect, should they occur. Next year, 2024, 25, I fully anticipate that there will be enough availability of nirsevimab. And we don't have the NACI recommendations yet, but at a minimum, the high-risk groups will be covered by nirsevimab, and probably there will be an increase in the number of populations that are covered. But will it go all the way to cover all healthy term infants born during the RSV season or under 8 months of age at the start? Stay tuned. I don't know. We'll see.
Okay, so one question from a parent perspective, because we did do a survey with parents to understand their knowledge of RSV. If they were given a choice, what would they prefer? But my question now, transition in the middle of the season, if you're going to transition, some kids already got palivizumab, and if some provinces decided to go to nirsevimab mid-season, a lot of parents answer in our survey the safety issue. Is would be a safety issue. Has been tested that, okay, you received 3 doses of palivizumab already, the season is about to start, and then January start, you get another drug, and that has a prolonged protection. Is this too much for the premature babies system? I think that's what question that parents did come up in the survey.
That's an interesting question, and it's valid, because the truth is there are no data on the safety or the efficacy of using palivizumab and then switching at some point to nirsevimab. However, given the mechanism of action of nirsevimab, which is it is identical to that of palivizumab, nearly identical to that of palivizumab, given the safety data that we do have on nirsevimab, which is identical to palivizumab, in the RCTs that have included several thousand infants who have received nirsevimab, I really do not anticipate any problems with or safety issues. There's no biological plausibility for a safety issue if a child were to receive 1, 2, 3 doses of palivizumab, and then it's actually cheaper to give another dose of nirsevimab to that child, and will keep them protected for the rest of the season. I would be very comfortable making that transition based on what we know. But I think it's a reasonable question, and I think we need to answer those questions openly, in the sense that, as I said, there are no studies that have looked at it, but based on what we know, there's really no reason to think that there would be any safety concerns there, or that it would not work as well.
And I think it's very important, because when you survey parents the first time in 2020, the bedside nurse was the first and foremost source of information for parents regarding RSV. So it's very important that everybody is well educated on what is happening to answer those questions for families. And we have a question here: the biggest challenge, how does all this information get out to parents regarding nirsevimab and the maternal vaccine? The need for education is imperative. How and who?
Yeah, I don't know if I'm the right person to answer that, in the sense that I think that, again, this happens closer to on the ground of what's happening. And I think that each program, because each program across provinces differs in the way they identify their high-risk infants, where do the infants go for their doses, who is administering the doses. So this is really more at a local level that these changes, or this relay of information, needs to occur. But it's going to start at the provincial level. It's going to start that the province decides that there is a change. Then it's going to need to circulate that information to the prescribers of these medications. Somebody's going to have to prescribe the nirsevimab, and then also to the people who administer it. And I think that the people who administer it have to be well equipped to be able to answer the types of questions like you just asked, Fabiana. So there should be, in my opinion, some form of teaching to these people who are going to be facing the families and are going to be asked questions. And I think the last thing we want is a family coming in for an appointment and then deciding that they don't feel comfortable with this because there wasn't enough information that was given, and then they leave with a child who is not protected against RSV in the middle of the RSV season.
Absolutely. So one more question. Does the cost evaluation include the cost of prolonged issues resulting from a serious infection?
So this was, I would say, hotly debated at the national level. And it was decided that the costs were only to include the cost associated with the acute infection, but not just the direct costs to the healthcare system regarding, a medical visit, hospitalization, the cost of the intervention, et cetera, but also indirect costs to the family. And I think that Kate pointed out some of those that are not negligible for a lot of families: parking, meals, loss of wages, et cetera. But the reason that we did not include long-term costs is that the data linking severe RSV infection to long-term consequences, unfortunately, is just not good enough to know for sure that there's a causal association. In other words, we know that having a severe RSV infection in infancy leads to an increased risk of wheezing and asthma later on in childhood. But what we don't know is it because kids who are already at risk for asthma are also at greater risk for a severe RSV infection if they get their RSV when they're young? They're just they have twitchier airways, more inflammatory, and if they get sick, they're going to get sicker during that first infection. And they would have developed asthma anyways, regardless of that initial insult. Or was the RSV an important modifier of the mucosa and the inflammatory pathways in their lungs that would later lead to reactive airway disease? So because we don't know that, and because we also don't know the magnitude of that effect, if it is real, it was thought there was just too much uncertainty to include that in the economic models, and the CDC did not include it, and it won't be in the Canadian model as well. But it's certainly an element of uncertainty with regards to the impact of these interventions.
Okay, so we have quite a long question here. Is there any data regarding multiples, twins, etc., receiving RSV prophylaxis and possible outcomes related to exclusion of one multiple but inclusion of another based on risk scores? Is there data to support that not having automatic eligibility of all multiples does not lead to more adverse outcomes for the one higher risk multiple? Ontario, we have seen a change in eligibility criteria where are no longer automatically including all multiples into the prophylaxis program if only a single one of the multiples met the risk scoring or eligibility criteria.
Right. So it turns out, I think that Ontario was a little bit of an outlier regarding that, and were being more liberal in their use of palivizumab than any of the other national guidelines were recommending. So AAP, CPS, and now NACI came out looking at the data. It's not because you have a twin that is at risk for severe disease that both should receive palivizumab. And part of that has to do with the fact that palivizumab doesn't actually prevent, it's not a sterilizing immunity. In other words, it doesn't prevent a mild infection. What it does, because it doesn't have any IgAs, it's just IgG. What it does is it prevents the infection from getting from the upper respiratory tract into the lower respiratory tract. But it will not prevent a child from getting a mild RSV infection and being contagious with their respiratory secretions as a young infant is, and they will. So giving the palivizumab to try and cocoon or protect the other infant doesn't make any sense biologically, and it would not be a cost-effective measure, nor it wouldn't benefit anybody. So that's why NACI was spelled that out quite clearly, and I think that's why Ontario came back to a more kind of standard practice with regards to that.
Okay, so one more question here. This is from a parent. Once my baby gets the vaccine at the current season, does he need to get the vaccine every following season? Does it work like the flu shot? If so, until when a former premium will qualify for it?
So another great question, some of which I don't have the exact answers for because, again, NACI will be coming out with those recommendations. But what I can say is that during the second year of life, only the highest risk infants are going to be eligible for nirsevimab. In the same way that only the highest risk infants are eligible for palivizumab in the second year of life. So think about babies with bronchopulmonary dysplasia who've had oxygen requirements in the previous 6 months. That's the type of infant that during the second year of life would be eligible. I believe the AAP has also, sorry, the CDC has also included profoundly immunosuppressed infants in the second year of life. But the point is here that the risk is much lower in the second year of life. That risk of hospitalization due to RSV is much lower in the second year of life, in part because many kids will have encountered RSV during their first year of life and will have some degree of immunity, but also because the lungs are more developed. The airways are bigger. So if you develop bronchiolitis, the plugging of the airways won't be as much of a problem. There are more alveoli, the gas exchange occurs better. So the risk of running into trouble and requiring medical attention is much lower in the second year of life. So really these types of interventions are only going to be for the first year of life, with a few exceptions of those very high risk infants in the second year of life. And how that will be defined, you'll find out in the spring of 2024.
So I also want to point out that on last Friday, Dr. Papenberg did do a webinar for parents only, answering a lot of parents' questions, and it's available on our YouTube channel now. So even if your healthcare providers want to share some of that information with the families, the information is all on our YouTube channel. Dr. Papenberg, a couple of more questions before we wrap it up. Can you have RSV, COVID, and flu shot? Will this mix of vaccination have side effects?
For RSV, we are giving it at birth, monoclonal antibody at birth, up until most time 6 months of age, prior at the start of the RSV season. But there is no problem with the co-administration of the COVID-19 vaccine and the influenza vaccine, which are eligible as of 6 months of life. I have not seen any data with regards to administering palivizumab and influenza or COVID-19 vaccines at the same time. I would suggest that there may be variability from one province to another with regards to that. So I think that's something that you really need to look at a province to province level. But certainly for influenza and COVID-19, kids are eligible as of 6 months of age. We know that premature babies with chronic lung disease, they're at higher risk of influenza, severe influenza, higher risk of severe COVID-19 infection. I would recommend in high-risk children that they get those vaccines in their first year of life, especially, and they can be administered at the same time. I'm not sure about the co-administration with palivizumab. You should check your local guidelines.
Okay, so if infants were to receive the nirsevimab, where should they get it? In the hospital, at the GP's office? What are the options?
So it's not available yet. So it's not available anywhere. So don't go calling any pharmacies. Don't call your GP. It's not in Canada, okay, at all. When it will become available, the provinces will decide where and who gets it, where they get it, how they get it. There won't be, I don't think there's going to be any available on the private market this coming year. Now, how would a program think about giving it? I think that the best place for it to be given for babies who are born during the RSV season is at that birth hospitalization. Before they even step out into the big bad world where RSV is circulating, they'll already have protection against RSV. And then for the kids who are under 8 months of age at the start of the RSV season, I'm not sure how the provinces are going to integrate that, but my suspicion is that it would be at the 2, 4, or 6 months age routine vaccination schedule. So wherever it is that babies get that in your province, because it varies from one province to another, that's probably how it would be administered. In Quebec, we're a little bit different. We don't have any 6 months routine vaccination in our schedule. So that would be another thing to consider for our province in particular that we're going to need to figure out.
It's a lot of work to do in this transition piece. So
Absolutely.
one last question. Do you suspect that families would be able to privately pay for nirsevimab as they can for palivizumab? If they are not deemed high risk, would you suggest families privately pay for it if available?
I guess I can't really answer the question because we don't, it's not available. It's certainly, and if it becomes available this year, I would be shocked and dismayed if it was privately available. That would be very, to me, seem very inequitable that we would not have supply for high risk infants and that it would be available outside of that context. So I really hope that it's not going to be available privately this season. Now, the following season, as supply increases, I can't answer your question because I don't know who's going to be eligible for it and who's not. It is possible, although I don't know that that's going to be the case, but it's possible that every infant, healthy or with medical conditions, under 8 months of age or born during the RSV season, it's possible that it will be given to every infant. In which case there wouldn't be any need to go outside of the public route. But it is also possible that the cost effectiveness analyses and other considerations may restrict its use to certain high risk groups, in which case then we can have that discussion of should a healthy term infant's family who can afford nirsevimab go and pay for it themselves. I don't know yet.
Okay, so as a parent organization advocating for preemie babies, you continually advocating for equal access to all preterm babies and high-risk infants. But Dr. Pappenberg, thank you so much for joining us here today. Always great to have you, to have your knowledge spread out among our community of preterm babies. So I'm very grateful that you accept our invitation to be here with us today.
It was my pleasure, Fabiana.
And to all of you watching us live here today, let me just share our contact information so you can be in touch with us. I want to thank you all for joining us live today, and a special thanks to our sponsor, AstraZeneca, who made education sessions like this one possible. And just a reminder, if you missed part of today's webinar, we will have available on our website, canadianpreemies.org, by the end of this week, and also on our YouTube channel, which is the Canadian Premature Babies Foundation. On our website, we also find many resources and support options available there. There's many topics. RSV is one of the topics that we cover that we know is very important for our families. And CPBF is a charitable organization and depends on support to continue its important work. Consider how you can support CPBF and its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. Thank you, everyone, and stay well.